Hello, everybody. My name is Katerina Polakova, and I'm from the Institute of Hematology and Blood Transfusion and First Faculty of Medicine, Charles University, Prague, Czech Republic. And I will speak today about TKI interactions with concomitant medication. Tyrosine kinase inhibitors, their bioavailability is influenced during absorptions. So I will speak about drug-drug interactions influencing absorption of TKIs. Then also very important factors is transmembrane transportation of TKIs. So I will speak about drug efflux and drug influx into the and outside cells of in the gastrointestinal tract. Then I will speak about CYP3A4 metabolism in the liver, which is highly influencing bioavailability of TKIs and distribution to the bone marrow to effectively target the CML cells. So first of all, I have to tell that tyrosine kinase inhibitors have a quite narrow therapeutic window, and interaction with other drugs can result in overdosing or undertreatment with optimal dose of TKI's administration. So some drug interaction of TKIs may cause the increased level of TKIs, which may cause side effects or that may cause a significant decrease of concentration or therapeutic concentration of TKIs. So patients do not respond optimally because of a subtherapeutic effect of TKIs. So tyrosine kinase inhibitors and may interact with other drugs in the stomach, so their absorption is influenced by changes in a pH. So co-administration of acid suppressive agents may increase pH, which consequently decreases the solubility of TKIs. Also inhibition of drug transporters and intestinal enzymes influence absorption of TKIs and consequently the distribution to blood. Talking about distribution and drug-drug interactions, there is little knowledge because more than 99% of anti-cancer drugs are bound to plasma proteins. So the more important talking about the drug-drug interaction is metabolism in the liver, because TKIs are metabolized through the CYP pathway, and the interaction with other drug may cause accelerated or increased CYP enzyme metabolism, which may cause decreased TKI availability and effect, or other drugs may inhibit CYP, which may cause decrease of drug metabolism because TKIs are metabolized in the liver. So, and this can cause the elevated level of unmetabolized TKIs. Also, there are some group of drugs that are anti-cancer drugs that are CYP dependent, meaning that the metabolism is important for the metabolized form has the pharmacological activity. So in case that such anti-cancer drug interacts with other drugs that inhibit CYP, in this case, the efficacy of anti-cancer drug with CYP dependency decrease the efficacy. So There is minor significance of drug-drug interaction in relation to elimination because major anti-cancer drugs, including TKIs, are predominantly excreted through the hepatic metabolism. So now I will show you several examples of TKI's interaction with other drugs that may influence absorption in stomach in relation to change in pH. So TKIs are present in ionized or non-ionized form, and it is highly dependent on the pH in the stomach and the pKa. pKa's pH at which TKIs have equilibrium between ionized and non-ionized form. And it is important to know that non-ionized form is less soluble. So non-ionized form of TKIs increase with a pH increase that may be caused by acid suppressive drug. And several of them are listed here. And the color indicates what kind of drugs interacts with dasatinib, imatinib, nilotinib, causing the decrease of their solubility and decrease of bioavailability. There are options, for example, what kind of drugs can be applied. Instead of this listed here, for example, imatinib can be applied together with H2 antagonists or with antacids or protein pump inhibitors. In case of nilotinib, protein pump inhibitors may be used concomitantly, but in case of H2 antagonists or antacids, this should be follow the time before or after nilotinib consumption. So now I will speak about the TKI's transportation and metabolism in intestine and liver and factors that influence their bioavailability. So transmembrane transport of the drug is a highly complex multifactorial process, which is illustrated nicely in this picture. So drugs are pumped into the cells by organic transporters, organic anion and cation transporters, proteins, SLC or multi-drug resistance associated proteins. So the SLC are pumping the drug into the cells, and ABCs pumping drug outside the cell. Also, there are drugs that go through the membrane by passive diffusion. And of course, there are important role of intestinal metabolic enzymes. So here are several examples of drugs that may influence TKI's transportation and metabolism in intestine and liver. So, for example, simvastatin. If simvastatin is co-administered together with imatinib and dasatinib and nilotinib, this may cause, in case of imatinib and dasatinib, strong simvastatin exposure because both TKIs inhibit CYP3A4. On the other hand, simvastatin inhibits PGP protein, which may cause some increase of imatinib and dasatinib exposure. So because simvastatin have quite narrow therapeutic window and inhibition of CYP3A4 by imatinib and dasatinib really strongly increase its plasma level, and this may cause the side effects in the patients. So it's better to change the simvastatin to parvastatin, for example. Other type of drug is from the class of anticoagulants, warfarin, for example. So in case of application together with dasatinib, we know that dasatinib has a thrombocytopenic effect. So together with warfarin, there is a high risk of bleeding. Interestingly, imatinib and also nilotinib inhibit CYP2C9. So this may cause the highly increased anticoagulation if warfarin is applied together with imatinib and nilotinib. So in this case, if warfarin is really needed to be consumed, it is important to perform a prothrombin time test. In case of using, for example, heparin inhibits PGP, which caused a highly increased imatinib exposure. Very similar situation to warfarin in case of dasatinib treated patients, again, due to thrombocytopenic effect of dasatinib. In some cases, this may cause a highly increased risk of bleeding. So next are other examples of DDIs. Verapamil may cause highly increased imatinib exposure because this drug is inhibitor of CYP3A4 and PGP, and also in case of dasatinib, again, there is a risk of highly increased dasatinib exposure, which in both cases, imatinib, dasatinib, may cause strong side effects. Other type of drug is cimetidine, and it's interesting here that cimetidine inhibits OCT1 transporter. This is well-known transporter of imatinib, so therefore cimetidine may cause decrease of intracellular imatinib exposure, and then patient may not achieve optimal response. Very important drug-drug interactions is in relation to QT interval prolongation. It is known that TKIs are blockators of potassium channel, which may lead to prolongation of the QT interval. And there are, I show you two examples of drug-drug interaction and QT interval prolongation in case of dasatinib and nilotinib together with quinine. Again, as I mentioned before, CYP3A4 is inhibited by dasatinib and nilotinib as well. Together with quinine, this causes highly increased quinine exposure, which highly prolonged QT interval. There is the additive effect because quinine also prolongs QT interval itself, and together with dasatinib and nilotinib, the risk is much higher. So it's better to not consume such a drug with additive effect on QT interval prolongation, and to change to other possible drug. And of course, monitoring of ECG is very important. So there are many other examples of TKIs interaction and other drugs from other classes, and I strongly recommend you to read a very nice review published in Blood 2011. Of course, I touch a little bit the topic about food and drink. In other words, what CML patients treated with TKIs should avoid. So it is very well known that the grapefruit juice also inhibits intestinal CYP3A4, which leads to increased imatinib, nilotinib, and dasatinib plasma level and may cause some side effects. In case of fatty foods, it is known that this may affect the bioavailability of nilotinib in terms of increased plasma level. Imatinib absorption was not changed significantly, and patients quite often ask physicians whether they can drink alcohol. So there is very, let's say, no effect or very small effect on imatinib treatment if alcohol is drinking in small amount. However, as alcohol induces CYP3A4, this of course increases toxic metabolites. So regular consumption of alcohol is not recommended because in general there is increased risk of hepatotoxic events, but in small amount it's allowed because, as I mentioned, the effect on TKI treatment is unknown or very, very low. So now I will speak about factors that influence TKI transportation through the SLC and ABC transporter, pumping TKIs into the cells and outside the cells in gastrointestinal tract and in bone marrow into and outside CML cells. So the best studied multi-drug efflux transporter in CML is ABCB1. It was found that it's overexpressed in patients in blast crisis and contributes to the reduced effectiveness of chemotherapy. In SLC transporters, the most studied imatinib transporter was OCT1, and it was shown by several studies that a major molecular response was frequently observed during imatinib treatment, regardless of the daily dose in patients with increased OCT1 activity. Genes encoding imatinib carrier transporters have been studied in terms of finding single nucleotide polymorphism encoding regions and association with response to imatinib in CML patients. So, for example, this SNP was found in exon 2 of the SLC22A1 transporter. That was shown it was associated with poor response to imatinib in CML patients of Asian origin. In this case of the SLC22A4 transporters and this SNP, the C allele was significantly associated with major molecular response. And widely studied and screened was a gene encoding ABCB1, and there were few reported SNPs that may impact imatinib response, but results were quite discordant. Very promising single nucleotide polymorphism was found in a promoter region of imatinib transporter OCT1, which is encoded by SLC22A4 gene. Patients with GC genotype have significantly higher probability of event-free survival. This is the blue curve compared to patients with GG genotype. This is the red curve. The green curve are patients with CC genotype. However, it is difficult to say what is the association with imatinib response because of a very low frequency of this genotype in CML population, also normal population. Interestingly, when we screened this SNP in patients from a Euroski trial, these are a group of patients in who imatinib was stopped. So we found that patients that carried the GC genotype had a significantly higher probability of molecular lapse-free survival compared to patients with GG genotype. So this is a very promising single nucleotide polymorphism and pharmacogenotype that may reflect or that may be a marker of imatinib response in CML patients. And currently, we are performing prospective study in our institute. So we prospectively genotype this SNP in CML patients at diagnosis. After imatinib start, we know that patients with GC genotype have higher probability of achieving deep molecular response and treatment-free remission after imatinib stop. Patients with GG genotype have lower probability of achieving DMR and TFR. However, patients with GC genotype, GG genotype may respond optimally, of course, and achieve sustained DMR. However, the defined DMR duration and imatinib duration for GC genotype and GG genotype would be definitely different, and I will show you several examples later. What is important that patients with GG genotype and no decreasing trend of BCR-ABL during first 3 months since imatinib start is quite convincing for our physicians to make an early switch to other TKIs. So in here, you can see examples of 2 patients carrying, in this case, GC genotype, in this case, GG genotype, both achieve deep molecular response during imatinib therapy. However, patient with GC genotype is MRD negative. However, is BCR-ABL negative compared to patient with the GG genotype that is MRD positive, and we can see many other similar examples. However, we have not done yet the statistical analysis because we are waiting for more CML patients to be screened and followed. These are 2 examples of patients that carry GG genotype, and you can see that in both cases, physicians made an early switch from imatinib to nilotinib, and in this case to dasatinib, because you can see that there is no decrease trend of BCR-ABL transcript during the first 3 or 5 months of imatinib therapy. And after early switch, you can see that both patients achieve major molecular or a deep molecular response. These are cases with patients with GG genotype in who the early switch was not done, and you can see quite a slow decreasing trend of BCR-ABL and a very slow achievement of major molecular response. And as I mentioned before, in these patients carry GG genotype, they would definitely need more time to achieve sustained deep molecular response, and thinking about imatinib stopping this patient would need definitely more time to increase probability of TFR. So we work on this more, of course. We need to do statistical analysis. And finally, I'd like to speak about another imatinib transporter, which is OCTN2 transporter, that is encodes by SLC22A5 gene, which is evolutionary copy of SLC22A4. OCTN2 is proved imatinib transporter, and also it is a specific transporter for carnitine. And carnitine, it's known, it transfers long chain fatty acids across the inner mitochondrial membrane for subsequent beta oxidation of fatty acids. So we studied whether there is competition between imatinib and carnitine in binding to this transporter, and whether this may impact the intracellular concentration if the competition is observed. I'll show you some important results from the presentation of my colleague Pavel Voda, who presented this work at last ASH. He worked with the two cell lines. This cell line is human rhabdomyosarcoma, and KCL22 is a cell line and its model of CML blast phase. Both cell lines were treated with imatinib during 24 up to 96 hours, and you can see in both cases significant decrease of intracellular carnitine concentration, which was measured by a mass spectrometry. So we found non-equal competition at OCT and 2. Preferentially, imatinib is pumping in, and this caused decrease of intracellular carnitine concentration. We didn't see effect when cell lines were exposed to carnitine and then to imatinib. So this was not influenced. So the imatinib intracellular concentration was not influenced, because we know that imatinib has other transporter through which is pumping in. So knowing this observation, we were curious whether decreased intracellular level of carnitine may cause decreased energy metabolism. After the treatment of both cell lines with imatinib and also with vinorelbine, vinorelbine is a specific inhibitor of OCT and 2, we observed the significant decrease of metabolites from Krebs cycle, significant decrease of lactate, and a significant decrease of ATP. So we work with the hypothesis that decreased intracellular level of carnitine due to imatinib treatment may attenuate mitochondrial energy production and disruption of skeletal muscle mitochondrial density that can be manifested in CML patients by side effects like fatigue, muscle pain, or cramp. And it is known that fatigue, muscle pain, and cramps is reported up to 50 to 80% of patients treated with imatinib. So we work more on that very interesting topic. So, and finally, I would like to conclude my presentation with this summary. I showed you that tyrosine kinase inhibitors have a quite narrow therapeutic window for optimization of drug exposure and resistance and toxicity reduction. And drug-drug interactions may cause tyrosine kinase reduced availability and therefore the poor response or increased exposure, and this may cause some side effects in CML patients. Currently, currently there are available palette of TKIs for treatment of CML patients. So we may speak or more personalized therapy in CML. So more attention should be paid in the individualized treatment management when TKI is co-administered with other drugs, especially in elderly CML patients. So there is a window for optimization of the dose of both drugs. Then I showed you a very promising marker, which is the regulatory SMP in the promoter region of SLC22A4 encoding, imatinib influx transporter that have a strong or significant association with imatinib response and TFR, and that can help physicians to decide for early switch in cases with unfavorable genotype and non-early molecular response. And finally, imatinib transportation through other transporter, OCTN2, may have impact on carnitine intracellular concentration and reduced carnitine intake that probably leads to attenuated energy metabolism, which can be manifested by side effects, including fatigue, muscle pain, or cramp. So finally, I'd like to acknowledge my colleagues, Pavel Burda, Alžběta Hlaváčková, and others who done the work on the OCTN2 transporter, which I showed you in my last slides. And I'd like to thank you for your attention, and I'll be very happy to email you back answers to your questions. Thank you very much.